consent to measure you?
Yes.
Do I have consent?
Yes.
Judging by the position of his feet, his center of pressure is in the midfoot area. His ankle joint is 1 inch behind the plumb line. His knee is 2 inches anterior to the plumb line. His hip is 3 inches anterior to the plumb line. Lumbar spine is 2 inches posterior to the plumb line. His shoulder joint is 1 inch posterior to the plumb line. His cervical vertebrae is 2 inches posterior to the plumb line.
The front hip bone is 1 inch inferior to the back. Judging by his shoe traction, his center of pressure is neutral. His chin is in line with the plumb line. His sternal notch is in line with the plumb line. His xiphoid process is in line with the plumb line. His navel is in line with the plumb line. His pubis is in line with the plumb line.
His hips are perfectly in line with the transverse axis. The center of pressure is still in the midfoot, but it is more medial on the left foot and more lateral on the right foot. His ankle joint is 2 inches posterior to the plumb line. His knee is 1 inch anterior to the plumb line. His hip is 2 inches anterior to the plumb line. His lumbar spine is 2 inches posterior to the plumb line. His shoulder joint is 1 inch posterior to the plumb line. His cervical vertebrae is 2 inches posterior to the plumb line.
The center of pressure is now shifted to the client's right foot. The chin is 1/2 inch to the client's left of the plumb line. The sternal notch is 1 inch to the client's left of the plumb line. The xiphoid is 1.5 inches to the client's left of the plumb line. The navel is 2.5 inches to the client's left of the plumb line. The pubis is 3 inches to the client's left of the plumb line.
The client's left hip bone is now superior to the client's right hip bone.
Here is a table with all of our observations and measurements. In orange, the table is condition 1, where the client was in a comfortable and active clothing. This is the baseline of our measurements of the assessment. The blue side of the table is condition 2, when our client's posture is altered due to a duffel bag on his right shoulder. As we look at the table, the client's sagittal measurements remain practically the same, whereas most of the difference is seen between the frontal plane of conditions 1 and 2. Some examples are from the frontal plane, where we see 0 inches from the plumb line, and the location of the center of pressure is neutral. Whereas in the blue side, it varies from 1/2 inch all the way to 3 inches, and he is shifted to the right foot on his location of pressure. In conclusion, the bag did in fact influence our client's posture and could pose him at risk of certain injuries. The center of mass, since he's leaning on his right foot, could affect his knee and give him knee pains, or spinal problems since his back is slightly curved to the right.
Do I have consent to measure you?
Yes.
Do I have consent?
Yes.
The active range of motion with the knee extended is 85 degrees to the hip. The active range of motion with the knee extended in the hip is 80 degrees. passive range of motion in his hip with the knee extended is 90 degrees. The passive range of motion in the hip with the knee extended is 85 degrees. The active range of motion with the knee relaxed in the hip is 110 degrees. The active range of motion with the knee relaxed is 100 degrees. The passive range of motion in his hip with the knee relaxed is 130 degrees. Passive range of motion in the hip with the knee relaxed is 120 degrees.
Here is a table with all the measurements and observations gathered from the hip range of motion assessment. The active mobility table in orange is the client performing movements unassisted, whereas the passive mobility in the blue table is the client performing the same movement with assistance from a professional. By comparing measurements and observations in the table shown, we can see that when an external force is applied to the client, it allows for greater range of motion in the hip. This is seen in the passive mobility table, written in blue. All angles in the blue table are greater than the corresponding angles in the orange table. This is the result of muscle fibers being more easily stretched when relaxed and acted upon by an external force, rather than contracted muscle fibers stretching themselves without an external force. For a specific type of clientele, this mobility assessment would be beneficial for client C. Since undergoing a right hip replacement, the client could test the range of motion in the right hip compared to the left hip. This would show if there was a change in the range of motion in the right hip, and if so, by how much. Lastly, with all the observations and measurements gathered, a decision can be made whether the client is able to be active, and if not, the client could be prescribed exercises such as hip flexor stretches or hip rotations to improve overall hip mobility.
The client's anterior reach is 52 centimeters. The client's posteromedial reach is 65 centimeters. The client's posterolateral reach is 70 centimeters.
The client's passive range of motion with hip flex and knee relaxed is 120 degrees.
We chose passive flexion in the hip with knee and ankle relaxed as our range of motion test. We chose this test because it was the most beneficial for increasing results in the Y balance test. We chose passive because if the client uses his passive range of motion as a benchmark to achieve with his active range of motion, the better he will get at the Y balance test. In other words, the closer his active range of motion is to his passive, the better he will be at the Y balance test. We chose hip with knee relaxed because the better the range of motion in the client's hip, the further he can bend to reach his leg back, and the better stability he will have. The client's Y-balance test results were good, and so were his range of motion test results, which shows that they are related. This proves that the better range of motion the client has in their hip, the better their ability to maintain balance while reaching back with the leg in the Y-balance test, and the further they will reach.
In my opinion, I believe the presenter Sasha Arbid presented with monotone speech in the video. He can improve his voice tone by speaking more energetically in his voiceover in order to boost the audience or viewers' attention and help them focus or listen better on the content provided in the video. Therefore, the presenter can practice speaking more enthusiastically with friends and family to improve voice tone and establish it as a daily habit. As a result, enthusiasm and an energetic tone could be the recipe for the future assessments that require presenting to improve communication drastically.
In the summary of video assignment 2, Sasha Arbid spoke with a slow pace and many pauses, which caused the summary to be harder to follow and caused it to have less flow. This can be fixed only by practicing. Sasha should practice more public speaking through presentations in school, interviews at jobs, or even speaking in front of a mirror in order to learn how to keep a steady pace throughout his summaries or presentations. Another way this can be fixed is by practicing and reading the summary beforehand and memorizing it more so that the pauses caused by reading and lack of memorization can be eliminated.
Eric did a good job with his summary, but one thing he could have improved was his eye contact with the camera. In order to improve this, he could have memorized the lines a little bit more, or just practiced a little bit more. Then he wouldn't have had to look back at the sheet so many times throughout the video.